Hello, I'm Dr. Neto and I'm here for more tips.
Hi everyone. Today's topic is a very common question that I have. People ask me, what is the difference of the preparations for class 2 amalgam and composite? So this is an amalgam preparation. I'm going to show you some characteristics that's very important. In my opinion, amalgam preparations are harder than composite, but some of the parameters that you have to obey is the first one that I would say is this occlusal preparation. The depth of it cannot be less than 1.5 millimeter all over, right? Because this is like the mechanic of the amalgam works this way. The amalgam cannot resist to occlusal loads if you make it less than 1.5 millimeter high. Okay, so ideally 1.5 to 2 millimeters. Then the occlusal, the interproximal box, you drop down to 3 millimeters. It's very important that you, when you prepare the interproximal box, I always start by interproximal box. I'm gonna give you hints about that later. You use something, you use a burr that you have a reference that you go all the way down to make sure that you make it at 3 millimeters. Because in real life patients or during your CDCA exam or your bench test exam, if you don't go 3 millimeter down here, you don't break the gingival contact and you don't remove the decay on the plastic teeth of accidental, or patients, you don't remove the decay as well, right? So 3 millimeter here, 1.5 to 2 millimeter here. And another thing that is important regarding amalgam is amalgam, it's not bonded, so we need to have mechanical retentions. So these walls here, they need to be slightly convergent toward occlusal, both lingual and buccal. So when you prepare at the end, when you're doing finishing, you need to bring your burr, tilt your burr a little bit to make it retentive, right? Same thing for the interproximal box. When you're preparing the lingual wall of your interproximal box and the buccal, you need to tilt the burr and make this convergence toward occlusal. It doesn't matter if you make one that is kind of parallel to the long axis, but the other one is tilted inward, so that's fine. As long as they are convergent to each other, that's fine. What you cannot do is to make it completely parallel to each other or divergent toward occlusal. So it means that the amalgam would break, right? Another thing is amalgam don't tolerate the amalgam restoration, they don't tolerate sharp corners. So everything at the end, these little corners, and especially this angle here, the axial pulpal angle, you need to round that to make sure that you don't break the amalgam. Otherwise, it breaks right here. In this case, that is a number 30. You have this kind of a M shape of the preparation, right? So you already have another type of retention that you have to have, which is like, imagine, for example, a preparation on this tooth right here. Your prep would be like completely straight toward the interproximal area. So the amalgam, although it's solid, it's kind of fluid somehow. So it flows toward the interproximal box. So if you don't have any retention, here you have the retention of those curves of this M shape. But if you have like a completely straight line on occlusal preparation, the amalgam tends to flow toward this area and it would break right here where it meets with the interproximal preparation. So what you have to do, some people like to call that, or most of the faculties, the professors, they call that dovetail. I don't like this name because I don't think it looks like a dovetail, which is that kind of preparation that you go here on the distal pit, or if it's a DO, you go to the opposing pit and you do a retention going this way and this way, or just one side. So you lock the amalgam this way to not to flow to that area. Another thing that is important is those walls here, the direction of those walls, they need to be parallel to each other. Remember, it's kind of confusing that I said they need to be convergent toward occlusal. That's when you look from mesial view, you're going to see that the box is going this way and this way. But when you look from occlusal view, this line here need to be parallel to this line. You don't make divergent like this and like that. I have another two to compare that it shows exactly what I mean. Like, for example, this one, you see that this buccal wall is tilted buccally. So what's the problem here with the amalgam? The amalgam, if you make an amalgam here, you see this angle right here in this corner. It means that the amalgam here would have like a smaller than 90-degree angle. So your amalgam would break right here at this corner, right? So if you make it flat, you're gonna have a 90-degree angle right here, so that the amalgam is resistant. So this is not a good prep for amalgam though. That could be for composite, right? So now what is the difference? So if I'm preparing this for composite, another thing that I have to say about amalgam, ideally you should have no contact whatsoever. So when you break, when you do your interproximal preparation, you break gingival contact down there, and you break lingual, and you break buccal. For composite, you should break lingual, you should break gingival, but you leave a tiny bit of contact on buccal, because they say that composite is harder to reestablish the contact if you break it completely. My next video is going to be about that. Like, yes, you can do good composite restoration with a good contact point as long as you know some tips to prevent mistakes about the contact point, okay? But generally speaking, ideally you should leave a little bit of contact where here on buccal. That's not the case, it's broken here, right? So if you have a little bit of contact, then what's going to happen? At the end, you will have contact anyway because you left it, right? So other things to compare regarding composite to amalgam is the depth of the box here. That could be 1 millimeter. The composite is more flexible and resist to this load. It cannot be less than 1 millimeter. You couldn't do 1 millimeter for amalgam, but you can do for composite. And the depth here in the proximal box is the same. Regarding the walls here, they don't need to be convergent toward occlusal. Once you remove the decay, as long as you get rid of unsupported enamel, you leave it as it is. So, and even those that parallelism between the buccal and lingual wall, as I told you, you don't necessarily need to do that for composite, right? So it could be parallel, convergent, divergent, it doesn't matter. Especially when you're dealing from gingival toward occlusal direction, it could be parallel, it could be divergent. What else? So regarding the contact, there are some tricks that I'm going to show you on the next video regarding the contact. But generally speaking, here, this area on amalgam, this length between buccal and lingual is going to be a little bit longer on amalgam than composite because you want to preserve that contact, right? So, and in theory, you know that ADEX before, when we were doing exams on patients, you could choose to do only interproximal box slot preparation if you see that the clinical case doesn't have involvement of occlusal pit, or if you were a premolar, you have no decay, no cavities on the occlusal groove. So you could do just a slot preparation. So for amalgam, you cannot do that. But for composite, yeah, you could do that. For ADEX, for patients, so you can do that. But for ADEX exam or for bench test, you need to do conventional amalgam preparation and conventional composite restoration. Okay? So that's it. If you want to suggest any topic regarding, if you have any question regarding this topic today and you want me to make another video to clarify that, please leave your comment below and see you on next video.
Thanks for watching. Don't forget to like, share, and subscribe to our channel on YouTube. And if you're interested in one of our hands-on courses, please check the link to our website below on the description, and see you on the next video.